Don, thank you so much.
Thank you.
It's just great to
Pleasure to be
have
here,
you
Susan.
here. Well, Don, as I mentioned, this very important Crossing the Global Quality Chasm report that you chaired the committee of came out last year. And as you kindly reminded us as we were prepping for this conversation today, two other very important reports, one published jointly by the World Bank, the World Health Organization, and the Organization of Economic Cooperation and Development, and then the Lancet Commission, all published around about the same time last year and all coming to the same stark set of conclusions about the state of healthcare quality around the world. You, again, were front and center here. What did those reports tell us?
I think it was a massively important series of events in 2018, Susan, and I think it raised the stakes for everybody in the world, including ECHO. As you said, I think crossing the quality chasm in the US in 2001 was a sort of turning point. A lot of places began to use that as an architecture for aim setting and then for systems changes that would allow us to have safe, effective, patient-centered, timely, efficient, equitable care. But it never reached the global scene. A number of us really right at that time began thinking, well, gee, you know, we should have the same kind of call to arms globally, and that's what happened in 2018. So the three reports are the National Academies of Sciences, Engineering, and Medicine report that I co-chaired with Sanya Nishtar from Pakistan. That was a American organization sponsored it, but the committee was global, was international, highly international. And working with Ashish Jha from Harvard, developed a series of estimates of the size of the chasm, that is, compared to care that should be given, safe, effective, patient-centered, timely, efficient, equitable care, to the care that is given, what are we losing in lives and treasure? And its estimate was that it's the number of deaths attributable to the gaps that we could identify, not just patient safety. This is failure to give people the care they should have scientifically, or drop balls in coordination and so on, is somewhere in the range of 5 to 8 million a year globally. That means that the number of deaths from quality defects compared to what would be possible if we had quality is larger than the number of deaths of AIDS, TB, and malaria combined. They don't even come close, actually. At the same time, independently, without any cross-talk at all, really, the Lancet Commission on High-Quality Healthcare Systems in the SDG era, it was called, met for a year. That was a highly international group with a group of advisors, and it came up with almost precisely the same estimate, something around 5 to 7 million deaths a year due to gaps in the care we give. The third report was, as you said, from the WHO, OECD, and the World Bank. It was a policy-oriented report recommending focusing ministries of health around the world on the problem. It also declared that this was a problem that was eroding lives in low and middle income countries at a level that there's nothing else compared to it. So I view 2018 as the year of the reports, and I'm pleading that 2019 be the year of action. We're standing here watching this devastation. The world is now committed to universal health coverage. That's international policy through the UN. Sustainable Development Goals now exist. Goal number 3 is universal healthcare coverage, but as we say in our report, that's an empty vessel if we can't find a way to deliver care of much more fidelity. I could spend a lot of time, and I'll give you one more view of it. Two of the reports, the Lancet report and the National Academies report, explored a kind of index, which I don't remember the exact title of it. It's like it's the percent of achievable benefit that is actually delivered through proper care in different sectors, like acute childhood illnesses, pneumonia care, TB care. And there's data, not in all countries, but in some, on what that percent looks like. And I won't get into the details of calculation, but the numbers are around, I think for the child performance metric, how much benefit do kids in the world get, it's 27% of the achievable benefit. In the TB arena, we have stunning research from India, thanks to Jishu Das at the World Bank. It shows that although physicians challenged on paper with with the story about a patient it's constructed so the patient has TB, so there's a proper way to manage them. Although the doctors do not bad on the paper test, when you actually go in the field, the success rates in actually identifying patients exactly like the ones in the scenarios is of the order of 10%. So this is a chasm.
And as those reports said, almost any place you look or have looked, you can see something not up to snuff, whether it's unwarranted variations in care delivery, whether it's adherence to published guidelines, even well-accepted, broadly distributed guidelines, whether it's rates of flu vaccinations, whether it's diagnostic errors, whether it's healthcare-acquired infections. It's really staggering, the magnitude of the deficiencies.
Staggering is the word I'd use. This is my field for 40 years. I thought I knew this stuff, but I had way underestimated the degree of the burden. And it is. It's certainly plaguing low and middle income countries. But believe me, the OECD nations and the wealthier countries are bearing a significant burden.
It's just one of the statistics on the high income countries that even I found appalling. 15% of total hospital spending in high income countries going to correct preventable complications of care. Yeah. That is staggering.
That was that was an OECD report. I mean, you couldn't get better vetted than that, and that was it. Wow.
Well, obviously much to be done. And to go to the Lancet Commission report, the phrase that they used front and center, now we need active learning systems. We need, first of all, we need leadership at all levels, political and throughout healthcare around the globe, to own this problem, identify this problem and own it, and then we need active learning systems. Since you created an active learning system at IHI, talk about how you see that playing out now.
Yeah, well, it's a horse race between proper theory and improper theory, in my view. I don't want to be doctrinaire about it, but I guess I feel doctrinaire about it. So we have a serious set of issues laid out there. There really are two views of the remedy, to way oversimplify. One I would call the incentive demanding view, which says we just have to make these people try harder. You know, that workforce out there, look at how much they're screwing up. We need to tighten the screws. Value-based payment, incentive payments, much more regulation, even markets used to force behavior. It's as if people could do it, they just don't choose to do it, and we have to solve that problem. I'd say that's the hegemonic view. That is actually how, if you watch corporations manage or governments do their work or ministries of health, unfortunately, that theory that trying harder is the problem, not trying hard enough is the problem, is very dominant. And I think in a way our task globally is to change that thinking as much as we possibly can. All three reports speak to this, and the Chasm report from 2001 spoke directly to it. Yes, we labeled this chasm, but that report was important in another more subtle way, which is it talked about systems. It said, if we build the system right, these good people who go to work every day to do the kind of stuff we hear about at this conference, they have a better chance of doing that. So that shift from effort to systems is a crucial one. W. Edwards Deming, the great teacher of quality, used to say, trying harder is the worst plan. And I really believe that. It's bad because it's demoralizing, it's quite inefficient. It also exceeds to the status quo because you're trying harder automatically, you're saying in the current system. So these are calls for systemic change in the way the work is actually conducted, and all three reports go there. Now, how do you support that? What does that mean in terms of the activities of a Ministry of Health or the CEO of a hospital or the chair of nursing? It means they have to become not table-pounding demanders of more, but coaches and nurturant human beings who are helping other new human beings to learn and grow. And that learning process needs its own approach. You need to be able to support learning. That's the magic of ECHO. ECHO, in its core, is about the importance and really the beauty of learning as a way to get to be better.
And the word that you used in the Crossing the Global Quality Chasm report was culture. creating this culture of learning. So, which I thought in and of itself was fascinating, because it's one thing to talk about systems and diagrams and flowcharts, but you really spoke to the need for this culture change.
Yeah, I mean, it's really, to me, operates at two levels. One is belief systems, which is do you believe that the problem is real or that it's not? Do you believe that the problem can be fixed, that you have any optimism at all? And if you think it can be fixed, do you think blaming and pushing is more likely, or do you think we can learn our way together to better? I guess that's culture. That's the ambient beliefs. I think it needs to be explicit, in my opinion. And when I got the chance to run CMS, my biggest agenda there was internal, which is to try to help that organization become even more a learning organization than it ever had been. And people want to do that, but that's a change in belief. The other side of culture is that culture is sort of a vague word. Actually, I'm not sure it means anything at all. It's just a collection of behaviors and like, where is the leader putting her time? Does the budget reflect an investment in people being allowed to study and learn together? Can you take risks? Nobody learns without failing. Is this an environment in which if you fail, people say, bravo for trying, let's try again? Or is it one that says, incident report goes in your file? There's a series of systems of learning that need to be put into place. And in at least the National Academy report, it's there. It begins to sketch it out. It's also nested because you have to think about, what does this look like on 6 West, or in this little clinic, or in this operating room? What do those learning processes look like locally? That's actually where it really matters. Given that you want that, what does the organization look like? What does that mean the CEO has to do? What about the chairman of medicine or surgery? They have to behave differently. They have to do different stuff to allow the learning to occur. From the ECHO point of view, they have to bring in ECHO, for example. And then there's the policy level, which is fascinating, and governments and legislatures, they create environments which either allow or impede those organizations from doing that job. And I'm going farther now today as my aging life, which is to say, I actually think it's also about justice. I think that it's hard to imagine at scale a learning environment that isn't founded on some basic principles of human rights and respect for people and safety, safety in a culture. And in my opinion, healthcare as a human right is part of that.
One of the fascinating statistics, I think this was from your report, more than 6 million excess cesarean sections around the world every year. Half of those in China and Brazil alone. And I thought of this when I read a op-ed in the New York Times earlier this week about obstetric violence in Brazil, written by a woman who had experienced this herself and really painted a picture of a culture that is not only not patient-centered or person-centered, it is certainly not woman-centered and mother-centered at all. And it spoke to a deeper issue, not just sort of lack of a learning culture, but really a culture that undervalues personhood of the very people who are allegedly being helped. And I wonder how much of that you saw in your report, and is that the kind of thing that's amenable to a new learning system?
Yeah, oh man, you got my brain whirring. In our report, we speak to that. We speak to the duties of integrity. We almost added a 7th dimension of quality: safe, effective, patient-centered, timely, and efficient, equitable, and with integrity as the other dimension. We didn't quite get there, but we said if corruption and failures of personal safety and things like that are ambient, you're not going to get the rest. That was Sanya Nishtar brought that from her experience in Pakistan. Very, very eloquent. We also talked about another thing in that report that is really, I think it's the biggest breakthrough in our report, the Academy report, which was settings of extreme adversity. There are several billions of people today who live in failed states, conflict zones, and refugee systems. We have no way to think about quality there, and we really need to. Those are places where people really are suffering, and the defects we're talking about in general are doubled there. So getting to those very needy areas is part of our report.
And just a moment ago, you used the word corruption. That was another
Yeah.
factor you identified.
Yeah, Sonia and Yishtar especially pushed in our commission the concept that the governments that are interested in improvement are going to have to deal with diversion of resources, supply chain corruption of all sorts, and I've really come to believe that that's part of the action. We're making quality bigger here. We're actually going to the nature of the communities we want to build and say, if we're not going to close that chasm without that kind of commitment. When I first met Sanjeev, I first met him in Boston, but then he invited me out here to his studio at the university. And, a lot of things impressed me, but the thing that impressed me the most was that he wasn't talking to me at first about bandwidth and cables and layouts and protocols. He was talking about values, respect, love. I mean, it was weird, but ECHO's founded on a values system, then connected to the technology, and it wouldn't be anywhere near what it is if it didn't start there. The same is going to be true about the quality journey globally.
We wouldn't have this audience today if they weren't all connecting to those values. Another factor that you identified is that so much of healthcare around the world, less so obviously in the industrialized countries, highly developed countries, but in much of the rest of the world, there's a large informal sector delivering care. These are not people who were highly educated or highly trained. They may be sincere and even good at many of the things that they do, but it is a different challenge to disseminate best practices or promising practices in the informal sector. Talk about that.
Yeah, you read the report carefully, Susan. There were 3 breakthroughs in that report. One is about failed states. One is about corruption, and the third is this one about the informal sector. So the data look like this. There are countries in the world, big ones, where 70% of the care is given by people who are not licensed, formally trained professionals. They live in communities. They've got a role in the community, which is a healer role, but it's not been acquired through anything that the normal systems of education and licensure and certification respect. That's called the informal sector. It is massive, and it can be 70 or 80% in some countries.
70 or 80%.
I gather that in the global health community at large, a common way to view it is to say, well, we can't deal with them. They're not under government control. They shouldn't be doing what they're doing. It's kind of like a rogue system. That would be not an uncommon view of that, but it's a wrong view because that's where people are going. They're telling us with their behavior that they want to go to people they trust in their communities who don't fit the models of preparation and supervision that we have. I will tell you that the quality studies of that sector, although the care is not very good, it's not actually a heck of a lot worse than in the licensed sector in a lot of places studied. The numbers are so remarkably the same. So our report says, how could we close this chasm unless we embrace that sector? And exactly what that's going to mean, we don't know. But it means that we're going to have to work on quality in the informal sector, which will kind of make it a little more formal, won't it? But we're putting that challenge out there, and I think that actually, once it's understood, will be a very controversial recommendation. But I've come to believe it. Back to ECHO, how are you going to reach out to these village practitioners or in cities? They're practitioners not in normal institutions, and we got to find a way to reach them. I think we might have some of that answer in this room, and I'll bet there are people in the room already doing that. By the way, I don't claim to be an expert on that.
And as the reports all noted, we are facing enormous workforce challenges, even among the licensed, trained, et cetera, sector. Here in the United States, obviously, we're living through that now with the shortage of people who are trained and willing to deliver medication-assisted therapy in the case of treatment, in the case of opioid use disorder. We talked about that on a panel this morning. And then, of course, we know this problem reigns in spades over so much of the rest of the world. So putting all of that together, let's talk about all of the capabilities and the variations that you've identified in the ECHO model that could address this situation.
Yeah, well, the gap is phenomenal in terms of workforce, if you assume the current system. But what we know is we can't populate the future system with the legacy workforce. The number of doctors and nurses we need it's incalculably large. It's probably unproducibly large. I mean, maybe there are ways to prepare a new kind of doctor, a new kind of nurse in a much more efficient way. Devi Shetty, the wonderful surgeon from India, is actually been advocating for quite some time about a new way to think about the preparation of physicians, which is a distributed system, not one located in centralized medical schools, but actually is occurring all the time, all over in a country. And he believes that the enormous gap that would exist just for physicians in India could be perhaps met if we think differently about preparation. And ECHO might have a play there. I think the same would be true of nurses, where I don't remember the number. It's several millions of nurses behind already globally, and it's just getting bigger faster. So there could be some leverage there. But the other way to think about it is what Sanjeev calls force multiplication, which is you take the existing workforce plus some, say how could they be even more effective at what they do? And this digital revolution, not just ECHO, the digital revolution as a whole, I think it's the first major technological frontier that I think may deliver on the promise that that was suggested. When I sat in that studio at ECHO and with Sanjeev, and I think the session I was at was dealing with frail elders, we had these 8 or 10 experts around the table and 20 little clinics, and we were all in it together, and all of that information was being leveraged, not just from the expert table to the clinic, but from clinic to clinic. You could see it happen in real time. That's building on abundance instead of on scarcity. And I think the possibilities are enormous. Culture change, yes. It means we have to begin to believe that people who we didn't think could do stuff can do this stuff, and that's good. And we're going to encourage that, and that's going to challenge us all. But we can't create the future with the current configuration. In England, they just published a document I believe is a very important document called the long-term plan. It's not clear, is it 10, 20, 30-year plan? It just came out of the NHS January 7th, and it lays out a framework for the new National Health Service in England, which is stressed all the ways we just talked about. And one of the proposals there is that they're going to, in a very, very short number of years, they're going to try to get 30% of the primary care to be virtual. And there's no question they can do that. And so instead of wringing their hands about not enough GPs, they're going to leverage what they have if they execute. Kaiser Permanente now does half or more, I think, of its dermatology consultations use teledermatology. And nobody moves, and it happens instantly. And they don't need more dermatologists. They need to think open-minded about how to give people help.
And as we think about the capabilities of ECHO, we know even, and you've used this phrase again, the various variations of the ECHO model and the permutations that can be had. Tomorrow we'll hear, as we discuss what's going on in India, how even vaulting from the Zoom platform to WhatsApp has created broader communities where people don't just get together for these scheduled ECHO sessions, they're communicating with each other all the time about clinical issues.
It's so exciting. It's a challenge to the ECHO team that they're up to, which is the typical challenge for a brilliant inventor, which is you built your thing, it took you years to do it, you spilled blood and sweat over it, and now you've built it and it's great. And it's your Fabergé egg. This is how you do it. This is how you do ECHO. And you're right at the start, and then you go and start to teach it to people, and they say, oh, okay, I'll do that. But then it starts to spread, and it can't spread without change. So as the inventor, your challenge is to decide whether you keep control because it's the right way to do it, or whether you begin to say this variation is knowledge. It's knowledge that people out there are adding from their local context. And that knowledge is spreadable too. So one of the great challenges and frontiers for ECHO to me is to celebrate the variability, don't fight it, standardize what has to be, but celebrate the variation and then learn from the variation, hear back, and develop this learning community, this global community of people. And ECHO in some form, somewhere, 3 years from now is going to be nothing like even Sanjeev Arora imagined. It'll be different and better for that context. That learning, I find that really exciting.
So we should go with the flow, as it were, as the ECHO models evolve around the world.
It's another version of respect. It's trust the people that are taking your idea and using it in their village or their country or with their language or with their history. They are just as smart as you. might be smarter, and at least for the local environment. And if you can trust them, what comes back will be even better than you sent.
All right, we do want to open this up, this conversation up to all of you in the audience. So once again, if you do have a question, raise your hand nice and high. We will get a mic runner to you. Please identify yourself by name and affiliation. And we're going to take a few questions, and then I'm going to circle back to Don, because I think he's got a call to action in mind for you. So we'll give him a chance to
Susan, I have a question.
well. Yes.
I'm all the way in the back. Clark Wigley. I'm a friend of ECHO. So Don, if you were Dr. Aurora and you were in charge of ECHO, what are the 5 things you do with ECHO on a global stage?
You want to give him 3?
All right, 3.
Okay.
I worship Sanjeev, and I hope that the first Nobel Prize for healthcare system change goes right to him. I think he's doing it all right. I guess the things that I like the most about what I'm hearing now is, to dream big. I mean, I think don't give up on the billion, but it's not going to be done by arithmetic, by growth. It has to be done by geometry. And this idea of leverage, finding the leverage, finding how you don't have to brute force the spread, but you release the spread is the most important thing I see Sanjeev doing, and most important advice I could ever give him, which is release the energy, don't control anything. I think that we do still need to, I think it's good to attach ECHO to the global agenda. The WHO Universal Health Coverage Agenda, the SDG agenda, and the, I'll say the quality chasm agenda that's now laid out in the 3 reports. That's very good grist for ECHO, and I think I like the synergy of saying to the Tedros at World Health Organization or his colleague, you want to do this and we can help. So instead of, it's just staying attached to what people care about. Maybe the third frontier, and Sanjeev talked to Sanjeev about this, and Susan actually and I were talking about it at lunch a bit. So look, the reasons we get sick, despite all the defects in healthcare, the reasons we get sick don't have to do with healthcare at all, really. Healthcare doesn't generate illness, it's a repair shop. And we should fix the repair shop so it's working as well as it possibly can. But unless we get connected to the social determinants, we can't make a healthier world. It's not a good way to do it. So that kind of systems thinking it's around. I worship Sir Michael Marmot in England, and have recently given crafted a speech about his work, just so we're aware of it. He says it's working on the causes of the causes. And we're unable to do that. In the US, we cannot get the resources over to the generators of illness. We're confiscating the resources in the repair shop. And that's a policy issue we're going to have to try to fix in this country. ECHO can help globally on this as ECHO begins to think about those causes of causes, and it is. What can we do in education? What can we do in creating an environment for more physical motion and activity? What can we do about the criminal justice system? What can we do about what can we even do about income inequalities? And I think ECHO as maybe some kind of assistant in the social change process that will work on social determinants, I think is a really good frontier. Hard to know how to cover it, how to pay for it. This is a redistributional issue in a world that has trouble redistributing wealth. But I think ECHO will turn out to be quite helpful there. I've heard recently that there's some good work going on in schools, and as a pediatrician and father of 4 and grandfather of 7, I say that's a good place to start. Toxic stress, adverse childhood experiences, and helping kids who are under severe stress do better. How could we help there? That would be a good example.
Great. All right, let's take another question, please.
I just wanted to, I don't have a question. I wanted to, first of all, thank
Your name,
you,
sir?
Don.
Yes.
Don, I want to thank you. I know how busy you are for coming here. We are so honored. On behalf of this whole movement, I want to express my gratitude to you for coming. Second, I want to express my gratitude for giving birth to quality movement and accelerating it in healthcare in the United States, for founding the Institute for Healthcare Improvement. and making us all aware of the quality chasm that exists and how we need to work hard to bridge it. And third, and most importantly, I want to thank you for being the voice of the conscience that has to emerge in the healthcare system. Because without the emergence of that conscience, even system change will not be enough to improve our healthcare system. We have to have that voice that you articulated of justice and equity. And then the systems will evolve to meet the voice of that conscience. And so thank you for being that voice, and we are really grateful to you.
We're here. We have another question. Again, it's difficult
Over
to see.
here, there we go.
Thanks very much. My name is Chris Koenig. I'm from San Francisco State University. I'm a big fan, Dr. Berwick, of your work, especially Confessions of an Extremist. It's one of my favorite pieces that you've written. I'm interested in the rationale for calling the traditional medicine as the informal sector of providing healthcare. Seems like the other aspects are, pretty straightforward, and I mean, corruption and failed states. Can you talk a little bit more about why you and the other folks called it the informal sector rather than recognizing the wisdom of traditional cultures and healing traditions that sort of may be outside of evidence-based as we currently understand it? It seems almost a kind of a colonialist mentality towards traditional wisdom and knowledge. So maybe you could just elaborate that a little bit.
Yeah, thank you, Chris. This was new to me. Even though I chair the committee, I was not the expert, and that term emerged from the group, people from Kenya and the Cameroon and Chile, and it is the term used. That just apparently is the ambient term. Maybe it does reflect some colonialism view. I don't know, and I welcome a different way to think of it. I think your question actually does raise a challenge that we're going to have to think hard about, which is the nature of evidence. In the end, I think we need infinite respect for the indigenous cultures and the knowledge, the knowledge in communities. I guess I do have a little trouble giving up the part of my brain and my training and my persona, which hopefully isn't colonialist, but might be, which says we still have to ask tough questions of what people purport to do. And I'm sure that traditional healing, for example, has a lot. I know it has a lot to offer. I watched it when a member of my family was desperately ill for a long time, and when she finally turned the corner, is because I know she went to a place with open air and a healthy environment, much better than the drugs. On the other hand, not everything works, not everything helps, and some things that we think help hurt, and I do think we should probably maintain some sense of commitment to science as a foundation for action. And I would rather embrace that world of effort, bring it into an honest inquiry than to say it has a free pass. It doesn't, in my view. I hope that's not too arrogant.
And while we're on this point about evidence, let's take the evidence question back to the entire ECHO enterprise itself.
Yeah.
We know from the ASPE report that was discussed yesterday, the Deering report, there is a desire to have more evidence that ECHO and all of the activities that take place under the ECHO mantle result in better outcomes for patients, and to demonstrate that. And what is laid out in those reports is an extremely extensive research agenda, which we should all embrace. It is hard to get one's brain around how all of that research is going to be done, who's going to pay for it, et cetera. How does the ECHO movement understand the outside world's demand that it produce evidence up against its desire to do so much because there is so much to be done to improve the quality of care?
Well, if you don't let it leave the room, I'll tell you that I disagree with the agenda. ECHO works And anyone that thinks it doesn't just has to be in the environment to see that it can work. It can really, really help. So if someone shows up and says, sorry, Don, we have to have a randomized clinical trial that has yes echo, no echo, I'd say you're wasting your time and my money and the time of the people that could be helped. There's a problem here in the whole community's attitude toward evidence that I've written about, thought about, and been quite heavily criticized for saying that is not the way to ask questions about echo. Echo is a very interesting Model T that gets you around, and now day by day, place by place, we have to be asking what's the next thing to make better about it, and that's dynamic research. That's the constant enterprise of self-scrutiny, reflection, sharing, trying again, failing, trying again. That's the world of evidence that I think ECHO ought to be in. It's a non-linear, it's a chaotic system, but anyone that thinks of something as big or as complex as ECHO, as if it were a pill and a red pill, they don't understand. They don't understand. So I'm for lots of evidence, but more of the kind that my kids get every day when they're trying to learn my grandkids get every day when they're trying to learn how to ride a bike. They're accumulating knowledge. And this community has a duty, not just the opportunity, but the duty to pool your knowledge, ask tough questions, study each other, reject things that don't seem to be going well, and acquire the skills for self-study. But a formalist research agenda of high cost and long tenure and high viscosity, I personally don't agree with it. I will lose that battle, and so...
All right, you heard it here. You heard it here. All right, well, we just have a little bit of time left, and Don, I know you wanted to get to this notion of issuing, in effect, a call to action for the broad ECHO community here. And some of this, I think, comes out of the thinking you just went to a WHO meeting in Saudi Arabia. Talk about that, and what is your call to action for this group?
Well, at the meeting in Saudi Arabia was the fourth annual meeting of the WHO. It's called the Fourth Ministerial Summit. Next year it'll be in Switzerland on safety, patient safety. So there's now a big commitment in WHO to try to get a safer world in healthcare. We have the data about the number of errors and injuries. You quoted some of those, Susan. And to their credit, WHO has tried to mobilize ministerial level recognition and then action. And then in the middle of this agenda comes these three reports, which I think are as important, if not more important, than the Chasm report in the US. Well, what are we going to do? I mean, we can study them and shelve them and restudy them, teach them in our schools. We can kvetch about them or lament it. That's not what we need to do. We need to fix it. And so I would say this to anyone, to ministers of health, to WHO, to anyone, is that let's close it. Let's stop it. There isn't anything in those reports that can't be fixed with a decision to do it on the proper values frame and frankly, with some sense of redistribution of wealth as unfortunately one of the way stations. This community has tremendous ability to help. If the ECHO community says, we understand this global quality chasm and we are going to close it, I actually, personally, I can't think of one intervention, if I could call it that, one line of work more likely to help than ECHO. Others will help too, but you have a tool here to do that. I think proposing that how would you propose that? I mean, you do. You propose it to WHO, you propose it to the powers that be. A minister of health with a conscience, and most have a conscience, that reads these reports and feels them is going to not sleep well, because they're going to begin to say, what the heck can I do about it? ECHO has the possibilities of community showing up and saying, we'll fix it for you. So that's my call to arms.
And you put this so profoundly in the context of human rights. We've evolved to, it's a human right for access to health care, witness the goal for universal coverage, but the additional human right that promise amounts to nothing if you don't have a functional system.
Yeah, I think we're a world that badly needs to return to the moral framework. I'm not a religious person myself, but I'm moral, and just empirically, I don't really believe we could muster the kind of energy for for the changes, the profound changes in thinking and action that we need without a framework, a foundation as strong as morality. The other alternative framework is economics. It's the economic man and the market forces and the structural change that was tried years ago in the World Bank and didn't work. So I love ECHO because it unapologetically is willing to speak from a framework of morality. The other part of that it goes back to Sanjeev's comments about me were way over the top and remarkably inaccurate, because the quality movement that I get to be part of it's a movement of solidarity. What's going on here is not me. It's a group, as you know, it's a group of people who, for whatever reason, have decided to come together and do them together that they can't do separately. Same as ECHO is, and that's also part of the ethos, which is we're gonna stick together, which is very different from a lot that's going on in the world where falling apart seems to be the plan.
Well, even great movements need powerful leaders, and I think I speak for this audience in saying there's nobody we'd rather stick together with than people like you and Sanjeev Arora. So join me in thanking Don
Thank you.
for a terrific conversation.
Thanks so much.
Thanks so much.